Hello, everyone, and thank you for joining us. My name is Casey, and I'm with AIUM, and I'll be your host today. As part of our continuing education for healthcare professionals, I'm pleased to host this webinar, How and Why to Incorporate the 3 Vessel Views into Fetal Cardiac Screening, presented by Dr. Matthew Jansen, Dr. Nadav Schwartz, and Christina Worth. This program is a non-CME educational activity that is put together in collaboration with Samsung. After this activity, you should be able to describe the importance of 3-vessel view, obtain and troubleshoot the 3-vessel view, and relate abnormal 3-vessel views to fetal cardiac abnormalities. If you have any questions for the presenters during this webinar, you may type them into the Q&A box at the top of your screen. You will be able to submit questions throughout this webinar, but the presenters will not be addressing them until we complete their presentations. Today's webinar is being recorded, and you will receive a follow-up email within 24 to 48 hours with the link to view the recording. I would now like to introduce our first speaker today, Dr. Nadav Schwartz. Dr. Schwartz, please go ahead.
Thank you so much. It's great to be here, and I want to thank the AIUM and Samsung for sponsoring and putting together this talk. We hope you find it educational and maybe even entertaining, and we'll get right to it. These are our disclosures. Now, our goals here are to describe the utility of the 3-vessel view to help you diagnose congenital heart disease and to become confident in obtaining and analyzing this view in all of your scans. And we're going to do things a little bit differently. I'm Nadav Schwartz. I'm one of the MFM faculties here at Penn, but I'm partnering in this talk with Christina Worth, our lead MFM sonographer at the Hospital of University of Pennsylvania, and also our ultrasound clinical education coordinator, and Dr. Matt Jansen, who's one of our MFM fellows. And we're taking this approach because really often in the reading room in the ultrasound unit, it's a collaborative approach. Not every single situation will you be able to know exactly what's going on, and everybody brings their own perspective, from the sonographer to the trainees and junior docs, and then the old folks like me. So our hope is that we each will bring our own perspective to help you understand the 3-vessel view and hopefully incorporate it into your practice. Now, congenital heart disease represents 1% of all live births. We know that it's a big issue, and we know that the heart can sometimes be some of the most challenging anatomy to navigate when you're learning how to scan the fetus. But importantly, antenatal detection of congenital heart disease really can impact patient counseling, referral to tertiary care centers when appropriate, timing of delivery, postpartum and postnatal management. And most importantly, I think that compared to many other organ systems, the prenatal diagnosis has been shown with lots of evidence actually does impact the outcomes. And improving outcomes is obviously what we're all in this game for. Now, the AIUM guidelines have evolved over the years and have become increasingly more robust and widespread to increase the level of scanning and the quality of scanning across the nation. Now, there used to be that the outflow tracks, the right and left outflow track, were only included into the basic screening scan when technically feasible. It wasn't mandated as part of the standard scan. It was mostly the 4-chamber view and the outflow tracks when technically feasible. But over the last few years, the AIUM updated the guidelines to now incorporate the outflow tracks as part of the standard exam. And now the 3-vessel view and the 3-vessel tracheal view are what's included when technically feasible, as you can see on the screen. In the detailed scan, the 3-vessel view and 3-vessel tracheal view are indeed included. Now, the issue is that sometimes the outflow tracks are a little bit more technically challenging to get. And in our opinion, the 3-vessel view and 3-vessel tracheal view really have a very, very pivotal role to play, even in the standard exam, as much as possible. So we're hoping to get you some comfort around that, understanding how to use it to really help you on as many scans as you can get them on. Now, the 4-chamber view remains the bedrock of cardiac screening. It's the basic first, primary view that we like to use, and you can see so much anatomy on this singular view. On the left, we see the still image, and obviously the Sidney clip on the right. The more Sidney clips, in my opinion, if your system can handle it, it really gets to see the anatomy in a different way, in a more dynamic way. So try getting used to that as well. But in the 4-chamber view, we can see so much anatomy. We see the heart, obviously, we can the relative size. We see the position, we see the axis around 45 degrees off to the side. We can see the right and left ventricles. We see the AV valves. We have the tricuspid valve and the mitral valve. And we also see the fact that you want the mitral valve over here to be a little offset from the tricuspid. We want the tricuspid valve to be a little bit more apical, inserting into the crux over there. We see the foramen ovale, we see the two atria over here and over here, and we see the pulmonary veins. This is the descending aorta on the left side of the spine, and overall it gives you a sense of the chest. There's no mediastinal shift. The heart's in the center of the chest, pointing off to the left, and you got a lot of information. And again, the dynamic area, the dynamic views on the cine clip, you get a general sense of the nice squeeze of the heart. There's no pericardial effusions. There's so much you can get here. But despite all of that anatomy that you get, we do know that the detection rate from the four-chamber view for major cardiac anomaly is still very limited. And the literature has been consistent despite the improvements in ultrasound technology, software, training, education. The four-chamber view, almost by design, will only be able to detect 1/2 to maybe 2/3 of major congenital heart disease. And the obvious reason is because many congenital heart disease hide in the outflow tracts and arches, and which are not assessed almost at all in the four-chamber view. So there's going to be an inherent limitation to what the four-chamber view can provide. So that's why the outflow tracts come into play, as we discussed before. Now, we see on the left here, the left outflow tract. This is the left ventricle coming through towards the aorta. We like to see that the interventricular septum is continuous with the wall of the aorta with no breakage there. We like to see that the mitral valve is over here. And with this continuity and orientation gives us a lot of information on the left side of the heart. And here on the right side of the heart, this is the main pulmonary artery that's bifurcating here. It's branching into the ductal arch which goes down to the descending aorta, a branch pulmonary artery. And we get the sense of the main pulmonary artery with the pulmonic valve usually in this area right here. And this is obviously giving us a lot more information of the outflow tracts. But again, it's a little bit more difficult to obtain, a lot more manipulation of the probe, and not always so easy to be able to look at the relative differences in comparing the right and left sides of the heart. And so as we transition and talk more about the three-vessel view, you'll see that it can really give you some of that information. Now, this is one of the earliest papers that really described and gave some information about this three-vessel view as being just another transverse view of the fetal mediastinum, and it's just above the level of the heart. And Christina will go through more about the acquisition, but just to give you a baseline understanding of what we're talking about to put everything into context, this is the cartoon that was sort of put together in this paper, and we see here the main pulmonary artery, which would be the largest vessel in this view. Then we see the aorta, which would be the second largest vessel, and then the superior vena cava. And this is the relationship both in terms of size, order, and alignment is key, and you'll hear much more about that. Now, the pulmonary artery will often branch. You may not see all these branches in each of your views, depending on your angle, but obviously the pulmonary artery will branch into the two branch pulmonary arteries, as well as to the ductus, which comes directly posteriorly to the descending aorta. And here in this cartoon, the C here stands for carina, which is the branch point of the trachea into the bronchi. So this will not be a vascular structure, but this is an area, this is another piece of anatomy that you can often see in this view and in the three-vessel trachea view. And while we're not going to be focusing on the non-cardiac anomalies that much, if you're ever looking for something like a TE fistula or esophageal atresia, this is the area you'd be looking at behind the three-vessel view. Now, here we see with ultrasound representation in addition to the cartoon, so you guys can see back and forth what we're trying to look at in terms of the anatomy. On the upper left is the three-vessel view. Again, the pulmonary artery up here going straight back to as a ductal arch to the descending aorta. Then we have the aorta in the middle and the SVC, a cross-section right next to that. And here we see it in the cartoon, and they put in the trachea and the esophagus, which we don't see in the ultrasound picture right now, but if they're dilated, especially if they're dilated, you can see them back here. You can often see the thymus. It's not pictured that well in this image, but again, we're not, this would be the area of seeing a thymus gland, which is a normal large structure in a fetus and eventually involutes with increasing age after birth. And looking here, we see that the difference, this is just a parallel view above the four-chamber view, going through the mediastinum in the same, almost the same axis as when you're getting the four-chamber view. Just move cephalad up towards the head. And if you keep going a little bit higher up in the chest, with a little bit of a twist towards the shoulder, you can get this three-vessel trachea view. Now, it's a little bit of a misnomer because the goal of the difference between the three vessel view and the three vessel trachea view is not that all of a sudden you see trachea. You can sometimes see trachea in both views. But the key here is more that you're looking at the arches. Okay, so it says three vessel trachea, but I think it's a little bit of a misnomer. The goal here is, yes, you're seeing the three vessels, but the difference here is I see this ductal arch, but now I'm also seeing the transverse aortic arch. And this little V shape here, and seen down here in the cartoon, is a great view to be able to look at both arches, the direction of their flow, and their orientation to each other. And so we're seeing the exit of both the right and left side of the heart in the single view. And then the SVC is seen once again here, and here you see a little bit of trachea over here. So these are the two views. Again, three vessel view more pivotal, but there's additional information you can get with the three vessel trachea view that we'll continue to go through in this talk. Now, in terms of the why you should be using these, the data support it very strongly. And I'll just go through two papers just to give that argument. This is one of the earlier papers, a prospective cohort study of over 8,000 subjects with 32 cases of major congenital heart disease. And once again, it showed that the four-chamber view on its own only picked up around 2/3, as we said before, around 2/3 at most of the major congenital anomalies. However, you see on the right over there, when the four-chamber view with just the three-vessel view picked up over 80%. And it performed similar to getting the four-chamber view with one or both outflow tracts. So the three-vessel view on some level was just as sensitive to major congenital heart disease as the outflow tracts and much, much easier to get. Now, there are some potential limitations to this study, because if you would imagine that when they're doing this kind of work, they're doing the anatomy scan and the three-vessel view is being obtained during the same exam and by the same sonographer as the outflow tracts. So could it be that you're calling this, you have the same test characteristics because you already saw your anomaly in the outflow tract, and so you're then ascribing the anomaly to the three-vessel view? Does the three-vessel view have its own detection power and sensitivity, even independent of the outflow tract views? So in order to address the study from that angle, we conducted a study here at the University of Pennsylvania in collaboration with our friends next door and collaborators at the Children's Hospital of Philadelphia. And we approached it this way. We asked the fetal heart program there at CHOP to take 119 consecutive fetal echoes and whether they were normal or abnormal. And we asked the sonographers to pull out a single representative three-vessel image, giving us no other information, not four-chamber, not outflow tracts, nothing else, not even risk factors. And of those 119 echoes, some of them were screening and were normal, and 34 of them had major congenital heart disease. We then took those three-vessel views, again, in isolation, and showed them to two examiners, maternal fetal medicine specialists, and asked them if it was normal or abnormal. So no other information, again, no four-chamber view, no outflow tract. And sure enough, we saw that both evaluators were able to detect over 90% of outflow tract anomalies just by a single three-vessel view with no other pictures. And combined anomalies, when there was both a four-chamber and an outflow tract component, it still picked up almost 90% of anomalies. And if you take all anomalies in total, including ones that might have been isolated in the four-chamber view, it still picked up around 80% of cases. So I think that this hopefully convinces you of the strong power that this three-vessel view has in order to help you, work on incorporating it into your screening and diagnostic capabilities in your unit. So with that background, I'd like to give the mic over to Christina Worth. Again, she's one of our lead sonographers at the University of Pennsylvania, and she's wonderful, and I'm sure that you will enjoy listening to her as well.
Thank you, Dr. Schwartz. All right, so now that Dr. Schwartz has kind of gone through the utility of the three-vessel and three-vessel tracheal views, I did just want to touch quickly on a case that really demonstrates how critical they can be to detection of fetal cardiac anomalies. Okay, so for this first case, we have a patient that's presented for her routine anatomic survey. We have our cardiac images here. So we have our septal four-chamber view showing an intact ventricular septum here and her outflow tracts. Here we have the left ventricular outflow tract and the right ventricular outflow tract. And you can see that in these views alone, the cardiac images look pretty normal. So scanning up just superiorly in the chest, trying to add these 3-vessel and these 3-vessel tracheal views, now we sort of have this 3-vessel view coming into play. So we have a transverse view of the chest. This is just scanning slightly superior to the level of the forechamber. We have sort of that longitudinal view of the pulmonary artery and the ductus arteriosus coming up. We have a transverse view of the aorta and a transverse view of the SVC here. And we can start to get a sense of the number of vessels that we're seeing in the 3-vessel view, which we're seeing the normal 3, and sort of the orientation and the relationship between them. So we see a pulmonary artery that's the largest, a aorta that's slightly smaller than the pulmonary artery, and then we see the SVC that's the smallest of the 3. And then scanning up just slightly further superiorly towards the fetus's head, now we're getting into that 3-vessel tracheal view. And most of the time, this is just sort of a slide superiorly, but sometimes it does help to angle slightly in the direction of the aortic isthmus, trying to elongate the aortic arch. So in this view, where we're kind of looking at our normal 3-vessel tracheal view compared to our case, our 3-vessel tracheal view, you can start to get a sense that there's a little bit of a difference between the anatomy that we're visualizing in this case and our normal anatomy. So in this case, we're seeing more of a U shape with our 3-vessel tracheal view. And in normal anatomy, we typically see more of a V shape that comes to the left of the fetal spine here. And then just taking a little bit of a closer look at this view, we're looking sort of at the hemodynamics of these vessels. So we're looking at the blood flow through the arches. In our normal case, you can see that blood flow should go in the same direction in both arches. It should go up and posteriorly towards the spine. In our case, we get a sense that it looks like blood flow is in the normal direction. It is going up. We see 2 blue vessels. Minus this little red blip here where we kind of have a Doppler angle issue, but you do get a sense that you still see that U shape. And so kind of breaking this down a little bit more closely, we see the trachea here, and we see that the ductus arteriosus is sort of that pulmonary arteries to the left of it, but we do start to see that the aorta is to the right of that in respect to the trachea. So this case does indeed look like a right aortic arch. And right aortic arches, there can be different configurations of them. You can have situations where there's a right-sided ductus arteriosus and you have, instead of a U shape, more of a V shape, but on the opposite side. You can have the U shape like we did with this case, and you can have vessels actually crossing in front of the trachea and posterior to the trachea, which are clinically significant because those could represent a vascular ring. So that's kind of showing, this clip is showing an example of that. You have in this clip your right aortic arch, you have the pulmonary artery and ductus arteriosus coming up. You have your aorta coming up over here, coming to the right of the trachea, that's sort of right in the middle, central here, but you do have these vessels crossing in front of it. So this one was complicated by the presence of an aberrant subclavian artery, which is that blue that you're seeing coming across, and then the pulmonary artery going in front of it. And what sort of happens with these vascular rings, and you can see over here in these illustrations, that in a normal arch, nothing should be going behind our trachea. But when you have the vascular ring forming, you sort of have these vessels wrapping around the trachea, and that can really cause a little bit of strangulation to the airway, which can cause respiratory distress and problems in the neonate. So we do recommend that these fetuses be delivered at a tertiary care center in case there is respiratory distress upon delivery. So now that that sort of demonstrates how important this view can be, I just want to quickly run through the image acquisition and sort of the technical aspects of these views. All right, so I do think cardiac imaging in general can be kind of intimidating, especially I feel like to people who aren't so comfortable scanning or newer sonographers early in their careers. And I think that many of us are very familiar with this sort of complex diagram of fetal cardiac circulation. But I think when it comes down to it, there's 4 more main functions of the heart that are the most important for the sonographer to sort of eke out. And I kind of tell the learners in our department that it's important to make sure that we're sort of scanning with purpose or telling a story. And I really want to tell in my images what's happening and what's going on, and kind of use my images as a narration for the normal anatomy or the abnormal anatomy that I'm seeing. And so if you break down this complicated diagram into the 4 main things the heart is really doing and needs to have happen in order for a fetus to be alive, You can break that down into the heart needs to move blood from the heart to the lungs, so kind of to pulmonic circulation. Blood needs to return from the lungs and go back to the heart. And the heart needs to pump blood from the heart to systemic circulation, and then return back from systemic circulation to the heart. So those are the four main functions that the heart is really doing on a very basic level. And when I'm taking images, I constantly want to be thinking back to sort of this cycle to figure out how I can tell that story. So this is looking at my cardiac images. My four-chamber over here, my left ventricular outflow tract, and my right ventricular outflow tract. And so you can kind of get a sense that there's four chambers of the heart. They're about equal size. They look like they're in the correct locations, but where these three views by themselves sort of fall short is it's not really telling me the whole story of how the heart is doing the rest of those steps. I do see outflow tracts, but I'm not getting a great sense of how they are in relation to one another. I see on the right ventricular outflow tract, I see the pulmonary artery, and I do see the aorta, but I really want to see that relational anatomy that we see in the three vessel view. So that's where these the three vessel view and the three vessel tracheal view really come into play. So this is showing a clip sort of up through the four chamber into the three vessel view and the three vessel tracheal view. If you're going to only take one clip of cardiac images, this I feel like is the clip that definitely will tell the story. So this is showing the connections of the outflow tracts to the four chambers, showing how things are connecting, where they're going, the relation between them, all of that. In situations where there could be a cardiac anomaly, and if you have no idea what it is, this is the clip that I tell our sonographers to take. And this is a very easy clip to obtain. You're just sweeping superiorly in the fetus from that four-chamber view. So if you can get anywhere near decent to a four-chamber view, you can typically get these views. All right, and now just sort of breaking the three vessel view down a tiny bit. I just want to run through some of the anatomy here a little bit. So the first thing we have are three vessels. This is just superior to the heart. We have our pulmonic valve and kind of a longitudinal axis of our main pulmonary artery turning into the ductus arteriosus. Back here we have kind of the ductal aortic confluence. And we should be able to see a transverse view of the aorta here in the middle and a transverse view of the SVC here furthest out to the side. Other than those three vessels, we want to pay attention to anything else in the picture. So sometimes you may have more vessels, sometimes you may have other structures. So just kind of taking a look around, we want to look at the whole image, make sure we're telling the entire story. So you can see a little bit of thymic tissue up here in the anterior portion of the chest. You can see the spine back here. You can see the trachea here, and you can see the esophagus. You also sometimes can see a little azygous vein coming off the SVC. And we don't see that all the time, but I do feel like, especially on patients who image well and with some of our machines getting better and better and better, we are seeing that a little bit more often, but it should never appear dilated or large. So that's important to take a look at as well if you are seeing it. In these views, we do want to pay attention to the relationship between the vessels. So the main pulmonary artery should be the largest of any of the vessels that we're seeing. The aortic vessel should be kind of that middle-sized vessel, and the SVC should be the smallest of all of the vessels. And we don't typically measure in just a routine anatomic survey. This is an image I pulled off of one of our fetal echoes here, but just to kind of show the relationship and to note that there are nomograms that exist for vessel size in these situations. So if ever you have dilatation or hypoplasia and you want to look at the degree of that, you can look these measurements up for gestational age. And then moving further superiorly in the heart and then angling just slightly to elongate the aortic arch in the direction of the aorta here, kind of towards the fetal left, you can start to get a look at the three vessel tracheal view. So again, we see the longitudinal axis of the pulmonary artery and a little bit more of the ductus arteriosus. And then we see the anterior part of the ascending aorta along with the aortic isthmus sort of stretched out a little bit. You can still see a transverse view of the SVC, and you see the trachea over here. And then you should be seeing this vessel confluence coming to the left of the fetal spine. And then another thing I like about this view is it's really easy to kind of get an assessment of the hemodynamics of the arches. So it's really telling me not only how many outflow tracts there are, but not only the size, but where is the blood pumping and where is it going? And that can give us a lot of information. So in this 3-vessel tracheal view with color, you can see that blood flow does flow in the same direction in both arches. And so in this situation where blood's going from the anterior part of the chest to the posterior aspect of the chest, it should be blue. And over here, we do see, again, that blue shift. This fetus is in a different position than this one over here, so I don't want that to confuse anyone. But we also see this red. So the red, if you look back over here, is in the SVC. The SVC should flow in the opposite direction because it's bringing blood from the fetal head and bringing it back to the heart. So in this case, the SVC is coming down. Because it is a venous structure, it tends to have lower velocity flow. So you may not always see it lit up, like in this image over here, whereas other times you may see little blips of color. And then this is just showing that color clip of that same structure. And again, just to sweep superiorly through the fetus here. So that's getting the images. Now, anytime I'm approached with a new view or a new tool that I'm using in my ultrasound imaging, there's a couple questions that come to my mind. One of them is always the feasibility of that image. Am I going to be able to obtain it and how? The second is my approach to obtaining that view. Why am I obtaining it and what am I illustrating in my view? And my third question is always about optimization. So once I'm getting this view, once I'm able to obtain it, once I figure out what I'm looking at, how do I make that view the best I can? So I just wanted to run through some of those questions real quick. So going on feasibility, one of my favorite things about this view is that it's very easy to obtain. I think that's a win when you're trying to get any sonographer to start taking something routinely on any of our routine imaging scans. So here we have a fetus that's kind of in a suboptimal position for cardiac imaging. The spine is kind of over here at that 9 o'clock position. The apex of the heart is kind of down or posterior. This particular patient was a more challenging patient. Her BMI was 37. And we don't have the best view of the cardiac outflow tracts. Typically in this view, the right ventricular outflow tract and the left ventricular outflow tract would be very difficult to obtain. But just kind of by sweeping through the fetus, we do get all the way up through the 3-vessel and the 3-vessel tracheal view. So it's giving me still a lot of information about those outflow tracts, even though I might not be able to obtain the RVOT and the LVOT in this position. And if I'm not able to obtain them, thinking back to that paper that Dr. Schwartz had presented, this is still ruling out 91% of my congenital outflow tract abnormalities. And so this is giving us a lot of information, even if we're not able to get those additional views. Another example of why I think this is a very technically feasible image is this view over here, which we took on an 11-weeker, a patient who had a BMI of 38 recently in our practice. And there's tons of papers that support doing these views even early on, such as in the first trimester, kind of adding it into the nuchal age study patients, where we can get a lot of information about cardiac development, even in early gestational age. So this paper in particular took a look at 597 cases. They found that they were able to obtain the 3-vessel tracheal view when using color or power Doppler in 87% of patients. All right, and then moving into our approach. So one of the things I want to think about when I'm trying to figure out what exactly am I illustrating in my image is when I'm not seeing a structure that looks normal or when I'm not able to obtaining it, what is the story that I'm then telling? What puzzle pieces am I giving to put together to try to figure out the big picture of what's happening in my narration of this anomaly? And so here's an example that Dr. Jansen is going to run through a little bit more in detail later, so I don't want to give any spoilers about this particular anomaly. But here's an example of an abnormal 3-vessel view. I'm always surprised when I'm working with learners in our department when they tell me that they weren't able to obtain a view and I say, oh, did you have a hard time because of the position or do you think something's going on with it? And they say, I think something's going on with it. And so then when I'm ready to look at the pictures, a lot of times I hear, well, I didn't take a picture of it because I wasn't sure. Always take a picture of it, even if you think it's abnormal. I think that that's one of the biggest takeaways that I can tell. even if you think that it doesn't look the way it's supposed to look, this picture still gives us tons of information about what's going to go on. And Dr. Jansen's going to talk about a lot of different cases where this view alone really gave a lot of insight to the diagnosis on multiple different cardiac defects. So I just that's my pedestal that I'm standing on. I just want to give everyone that reminder. And then switching over into image optimization, I think that cardiac imaging in general is one of the things that we really want to make sure we're doing the most that we can to optimize our images. The fetal heart, usually at the 20-week mark, is only about the size of a quarter, so it's pretty small. And we definitely want to make sure that we're looking at it with as much detail as we can. So thinking back to kind of our sonographer toolbox, our main knobology things that we're always adjusting, focus depth gain, always taking a look at the frequency. Can I do anything to optimize it with that? Can I increase my resolution? Any of that stuff. Considering whether or not to use harmonics, adjusting my sector width if I need to, utilizing some other tools I have like HD zoom, magnification, dynamic range, and making sure things like my scale are set appropriately if I'm looking with color, and then my Doppler angle is good. Here are a couple examples of different cases side by side, optimized and not optimized. So this is just showing an example with frequency. Now this is another patient who did have a higher BMI. So I actually ended up liking the cardiac imaging of this patient a little bit better with just a lower general frequency. I felt like we lost a little bit with our higher resolution frequency on this particular case. And so with anything in ultrasound physics, it's always a little bit of a trade-off where we have to decide, is the additional information that I'm gaining by bumping my frequency up, then am I losing too much penetration? So sort of trying to find that balance. I tend to like imaging fetal cardiac structures with harmonics. I think it does a little bit to reduce some of the noise and give us a little bit clearer pictures. So this is comparing a fetus without harmonics and then with harmonics over here. And I do think this gave us a much nicer image. And then a lot of our machines today do have the ability to do some advanced image optimization features digitally. So this particular machine, this Samsung that I'm using, uses clear vision as something that the sonographer can control. And it's sort of an advanced optimization technique to remove artifact like speckle. And one final advanced optimization technique that I really like is shadow HDR, which is a feature that our machines have, which reduces attenuation from bony structures. And you can see how it kind of gets rid of some of these rib shadows over here. All right, so that kind of runs through some pearls and pitfalls of the technical aspects. I'm now going to throw it over to Dr. Jansen, who will begin to discuss interpretation of these views.
Okay, great. Thank you so much, Christina. And so now we're going to discuss kind of a systematic way to approach every 3-vessel view that you're imaging, and that will hopefully make you feel more confident and comfortable when you start seeing things that are abnormal. And then after we discuss the kind of systematic way to approach it, we're going to go through a number of cases that are going to allow us to kind of apply that technique to hone in on what specific diagnoses we may be able to see with this view. And so, you know, as a fellow learning the 3-vessel view and trying to understand both normal and abnormal, I really have found this paper here by Dr. Genti and others to be very helpful, especially because of the schematics that they have in this paper. And we're going to be showing these schematics alongside some of our images to really kind of highlight the pattern recognition that I think is really important within the 3-vessel view. And so for the stepwise method, again, we try to apply the stepwise method in all of the images that we see. And the first thing is really to just assess the number of vessels. Are we seeing the 3 vessels that we expect, or are we seeing too few or too many? And then what is the kind of size relationship between those vessels? Is one significantly larger than we expect it to be, or one appears smaller than we expect it to be? And also, what is the orientation of them? Are they in this kind of correct pattern going from largest to smallest? And in the 3-vessel tracheal view, you know, is it making that classic V sign, as Christina and Dr. Schwartz showed, down towards the fetal spine? And also in that 3-vessel tracheal view, what is the direction of the color Doppler flow as well? as we have discussed, the blood flow should be going back towards the fetal spine in both the aortic as well as the ductal arch. And if you see a discrepancy between one side or the other, that can also clue you in to some different possible abnormalities that we can see. And so really, as we now start to go through these abnormal cases, I really think that they'll be able to highlight the kind of vast majority of the different anomalies that we can identify with the three vessel view, because there are so many different ones. But I also would encourage everyone to kind of take this same stepwise approach that we just discussed and kind of practice that as we go along, just as you might do if we were actually kind of scanning an ultrasound unit and seeing these images come through. And so to start with the first case here, so we see a three vessel view, on the screen here on the left, and we're kind of analyzing it. We're starting to say, okay, what's that systematic approach? We're going to start by looking as, do we see the overall same number of vessels that we expect to? And so we see kind of 1, 2, 3, and 4 vessels. And so that immediately tips us off that, okay, maybe there's something different that we're seeing here that's not kind of the classic images that we were seeing before. But again, we're going to continue down this pathway. We're not going to kind of jump right to the diagnosis or anything. And we say, well, what's the kind of size relationship between them? And certainly it seems like, at least from this vessel on, that the size progression is what we would expect. And that also calls into mind, well, which one of these is the abnormal vessel? And so, if this is the size progression we would expect, then maybe it seems like this one over here is the vessel that is abnormal. And so schematically, this can be shown here from the same paper that I discussed before, just to kind of highlight that pattern recognition of seeing that fourth vessel on the side. When we go up to the three vessel tracheal view, now we're going to look and see that the orientation is the same as we would expect in that V pattern, as well as the Doppler flow in both of the arches is also in the same direction. But we do see this kind of other kind of signal over here that's actually in the reverse direction, and it's bleeding over a little bit. And that's also likely from this other extra fourth vessel here. And that is also informative to us about what exactly is going on. But again, I think, this is the clue to what's going on, but we still need to remember the other cardiac views that we have at our disposal. And so moving into a 4-chamber, as well as the nice clips that Christina and Dr. Schwartz showed us, when we can quickly go from the 4-chamber up to the three vessel tracheal view, we now can grossly say, okay, the 4-chamber, in this quick clip looks relatively normal, but really it's just the three vessel tracheal view and the three vessel view that is kind of highlighting the abnormality here. And so, this is a case of a persistent left superior vena cava. And we were able to tell that because that's what that fourth vessel is on that side over there. It was kind of the same size as the right vena cava. There was reversed color flow in that fourth vessel, showing that the blood is going to the heart as opposed to away like it was in the arches and everything. And an isolated persistent left superior vena cava on its own is not of great clinical significance, but it is an indication for a fetal echocardiogram, since it can be associated with other abnormalities. And so if we go back to the 4-chamber view, we can actually see some other signs of that could indicate to us this persistent left superior vena cava. And really what that is as you see with the arrow here, is that's this kind of circular structure just off to the side of the left atrium. And what that is that's the dilated coronary sinus that's draining the blood from the left SVC and then going to return that blood back into the right atrium. And so that's just another clue in the 4-chamber view that we can also get a hint and confirm the diagnosis that we expected in the three vessel view. I think that, with just the 4-chamber view on its own, especially when you're looking at the clips, this is a little bit harder to see because it can be obscured by cardiac motion when it was even really clear, even in that clip that we went through at the three vessel view, more so than it may be in the 4-chamber. And then, as we mentioned, that other anomalies can be associated with the persistent left SVC. And so certainly in this same fetus from the same case, on further kind of evaluation with the short axis showing color Doppler flow here on the left, we did see, evidence of maybe there's a VSD. And certainly with this, kind of more apical 4-chamber on the right, we see this color flow crossing the septum. And surely enough, we did find a very small muscular VSD in this fetus as well. And so now to move on into case 2. And so for case 2, we're starting with a 4-chamber view. And I think we can say from this first look at the 4-chamber view that it appears overall normal. We see the 4 chambers, we see the offset in the valves as well as the pulmonary veins kind of returning into the left atrium. But then when we start progressing our scanning and going to the next views that we know we need to get, like the outflow tracts, we end up with the left and right outflow tracts here. And I think now we're saying that these may not look quite as normal as we expect. This right outflow tract, certainly, we're not seeing necessarily the branching that we would want to see. And there's something about this left outflow tract that I just don't think feels right as well. But with just these, it's hard to say, well, what is the ultimate kind of diagnosis that we're going to say? You know, what other information could we get? You know, is this left ventricular outflow tract, is it overriding? Is that why it looks abnormal? Is this right ventricular outflow tract dilated? Kind of what exactly is going on? But I think if we move up to the 3-vessel view, we get a lot more information. And so here we see, you know, a clip with color Doppler through the 3-vessel view. And again, applying that same systematic approach, we say, okay, we actually only see 2 vessels, this large one here in the center, and then this other cross section over here. And that's shown schematically here in the cartoon on the side as well. You know, the orientation of the vessels is obviously a little bit hard to say when there's only 2 of them, but it does seem like it progresses from a larger vessel to a smaller vessel as we would expect. And the color Doppler flow, although there's some turbulence, is for the most part going back down towards the spine as we would expect, but there's no V kind of as we progress into the tracheal view. And so this is really kind of the classic, what's been described in the literature is the I sign. And really what this indicates is a transposition of the great vessels. And that can lead us to then assess kind of more technically challenging images, such as finding those classic parallel outflow tracts that really are the textbook picture to confirm a transposition of the great vessels. And I think that although the 3-vessel tracheal view there with the I sign is also really clear, it also just informs us to look for these other, you know, views to really even further confirm our suspicion. And so again, that's how we can see the transposition of the great vessels with that abnormal number of vessels in the 3-vessel view, as well as the I sign with that single large vessel going straight back towards the spine and not veering off to the left side of the spine and making that V configuration as we would otherwise expect. And so we'll kind of go for a different direction for, you know, case number 3. And instead of starting at a 4-chamber working up, we'll start just right here at the 3-vessel view, as well as the 3-vessel tracheal view. And so systematically, we see, okay, we have 3 vessels here. That's good. That's what we expect. That's what we see here in the tracheal view as well. We start looking at the size between them, and we say, okay, the pulmonary artery looks, you know, maybe a little bit bigger than the aorta as we would expect. And then we come over here to the SVC, and we say, well, there does seem to be a little bit more, you know, dilation in that SVC. It looks a little bit thicker than we would maybe otherwise expect, as kind of shown here in the cartoon, where that is, you know, a little bit enlarged, as we can see with kind of that, you know, hypoechoic area here. And so we then say, well, we're not sure exactly what's going on. Let's go and evaluate the 4-chamber again at this point in time to further help us aid in the diagnosis. And in this 4-chamber, we see, okay, the ventricles again look relatively normal. We're maybe getting some shadowing, you know, loss of attenuation here in the septum. But we see the atrium and the valves offset. We see a pulmonary vein coming in here as well. But I think a close look here at the retrocardiac space is actually showing 2 vessels as opposed to just the one that we would typically see. It's the descending aorta off to the fetal left of the spine. And so this vessel here to the right of the fetal spine also clues us into what's going on here, along with seeing a dilated SVC in that 3-vessel view, in the 3-vessel tracheal view. And so that can lead us to then progress to see kind of a bicaval view here, which confirms our diagnosis and suspicion that maybe what we were seeing is a dilated azygous vein, and then searching for the reason why we were seeing a dilated azygous vein. And in this view, we see kind of a bicaval sagittal view of the fetus that's showing the superior vena cava up here, cephalad, as well as the inferior vena cava, you know, below that. And we see that this is an interrupted IVC where we don't see continuation of the IVC through the infradiaphragmatic space. And so in this case, what we were able to show through this collection of images is that there's an interrupted IVC and that more of the body's venous drainage is coming back through the azygous system, as shown here in the 4-chamber, and then followed up into the SVC in the 3-vessel view. And the way that appears as we just went through in the 3-vessel view is with that prominent SVC and the abnormal number of vessels behind the heart in the 4-chamber. And so for case number 4, again, we go to the 3-vessel view here as well. And we start going through our systematic approach and we say, okay, we see 3 vessels here. We start analyzing the size between them and we say, well, so if this is the pulmonary artery, that looks normal, but why is the aorta maybe slightly larger than the pulmonary artery? And these can be somewhat subtle differences in the size. And that's another thing that we wanted to pull all of our attention to, is just how subtle it can be that this dilation is more than the pulmonary artery. And so schematically, we can represent that like this. And then in another image, just to make sure that we're actually getting this in multiple images and it's not just angle dependent or anything, we again see that the aorta is dilated compared to the pulmonary artery. In the three vessel tracheal view, we do see that V configuration coming together, but again, it still looks suspicious that the aorta is more dilated than we would expect. That being said, though, we can't be sure at this point if the aorta is actually what's abnormally dilated, or is it actually that the pulmonary system is smaller or more stenotic than we would expect. And we can't quite tell that from just the views that we've presented so far. We have to go investigating still. And so we go investigating, we look at the four-chamber, that looks relatively normal. And then we move on to the outflow tracts. And this is where we start seeing that this left ventricular outflow tract doesn't look quite normal. Certainly the right ventricular outflow tract, we're not seeing the branching that we would like. And that in the left ventricular outflow tract, we see that this aorta is overriding. And then we start having a suspicion for, could this be a tetralogy of flow? And certainly we didn't present it in these images, but we were able to confirm, other stigmata of a tetralogy in this case with the VSD as well. And so, really the main way to see that in the three vessel view is to really pay close attention to that size discrepancy between the vessels. And if the aorta is larger than the pulmonary artery, to then go looking for those other signs of tetralogy to see if that's what the confirming diagnosis would be. And so we still have a few more cases, but I wanted to also present follow-up from the same patient. Instead of at 20 weeks, this is that same fetus at 36 weeks with the tetralogy. And now we see in the three vessel view that this aorta really seems much larger than the pulmonary artery over here. And that in the coronal section, we can again see the overriding aorta that is straddling the ventricles here. And so again, is confirming our diagnosis that we made much earlier and is even more prominent here at 36 weeks. And so, the other anomaly that we wanted to make sure that we touched on that can, present with a dilated aorta, we're going to present from this paper by Anton et al. Here, which is a really great paper that reviews a number of different abnormalities that you can see in a three vessel view as well. And so in this case, what we're going to be talking about is a truncus arteriosus. And so what we see is we see a really dilated central vessel here, the superior vena cava on the side, but we have known from our systematic approach that this is not the normal number of vessels that we wanted to see. We then put color Doppler on, and we see some turbulent flow here, but we also see that the left and right pulmonary arteries can be branching off of that main central trunk vessel, and that schematically is kind of confirming one way that you can confirm a diagnosis of a truncus arteriosus, also through the three vessel view and the three vessel tracheal view. And so now moving on to our second to last case, here we see a clip through what is supposed to be a four-chamber view. And I think, to a lot of us, this immediately says, that there's something, definitely wrong in some severe congenital heart disease in this case. We aren't seeing four chambers, but the question is, well, what exactly is wrong? What are we seeing? And how can we more accurately kind of describe what we're looking at? I think one thing that happens is, certainly to myself as a trainee, going through this, seeing something like this, is then you start to, get a little bit nervous, you start to panic and try to figure out what's going on. But again, I think if we go systematically through our outflows, three vessel view, and our approach, we can kind of more confidently assess what's happening. And so then moving to the right ventricular and left ventricular outflow tracts, they may be a little bit difficult to image. Certainly this LVOT is, and the RVOT doesn't look quite like what we expect either. But then moving up into the three vessel view, and you may recognize these images as the case Christina said I was going to discuss later. We see three vessels here, but we see dilation in the pulmonary artery vessel, and in the Doppler flow on the tracheal view, we don't see that classic V sign because we're not seeing any flow across the aortic arch here. And so we can represent that schematically, as well as we can also measure those quantitatively, as Christina mentioned, in kind of more advanced fetal echocardiography as well. And so in this case, I think what we're concerned about is we're concerned that something is underdeveloped on that left ventricular outflow tract side, and that the aorta is small here. And so really that was a case of a hypoplastic left heart syndrome that we also diagnosed by seeing that the pulmonary artery was much greater than the aorta. And this is, as we know, a very severe congenital heart disease that, we knew the four chamber was abnormal, but by looking higher up at the three vessel view, we could say, okay, it seems like the outflows from the left side is actually what is concerning to us. And that probably was, the right ventricle that we were seeing in the four chamber. And we just feel more confident in this overall diagnosis. And I really want you to keep that pattern recognition from that last case in mind when we look at this last one here. In this last one here, we go straight to the 3-vessel view because at this point, we're on case number 6 in this talk, and everyone is totally convinced that we're going to go straight to the 3-vessel view. And here we again see, our normal approach, that there's 3 vessels, but that this one here, which is the pulmonary artery, is much more dilated than the others, and that the aorta here, doesn't seem to progress normally down that pattern. And schematically, we show that here again. And then on a color Doppler clip here going up kind of towards the tracheal view, we see that, we may get a quick flash of that V sign like we like to see, as well as that the flow direction is going towards the spine here. And if we take a still image from that, really kind of to highlight the little bit of flow in that V shape that we see at the tracheal view, and it's a little bit of a skewed angle, but I think still this is showing us that there's actually maybe potentially some retrograde flow going away from the probe and away from the fetal spine here in this V. And then we start looking at the 4-chamber and we see, an RV to LV size discrepancy here as well, that this LV seems to be underdeveloped, although it is apex forming, and it does seem like it has a normally functioning valve and normal contraction function. And then we go to our outflows track here with the left ventricular outflow track, and we see some increased velocities and turbulent flow through the left ventricular outflow. And then in our aortic arch view, we can kind of confirm that, the reason that we were seeing retrograde flow in the 3-vessel tracheal view is really that this represents an aortic coarctation with retrograde flow due to this atresia here. And the reason I wanted to contrast this to the prior view with the hypoplastic left heart is that although they both presented in a similar fashion with a smaller aorta in the 3-vessel view, that by sliding up also a little bit more to the tracheal view and putting the color Doppler on, we were able to catch that retrograde flow in this case and not see any flow at all in the hypoplastic left heart case. And so now I want to turn, after going through those abnormal cases, I want to turn the presentation back over to Dr. Schwartz to go through another really interesting case that we had from our ultrasound unit.
Thank you so much. Great job, Matt and Christina. So that was a great overview of normal and abnormal, and hopefully everybody is more than just convinced of the utility of the 3-vessel view to really provide tons of insight into your cardiac anatomy and anomalies, and increase your detection rate for screening for anomalies. But then also, once there's something off, having a better understanding of the relationships of the vessels and how to help decipher what's going on. So there's both screening and diagnostic utility to the 3-vessel and 3-vessel trachea views. Now, in this case, it's not just something we put together in a sort of order just to make a point. This is actually how this diagnosis, which is a little bit more of a rare zebra diagnosis, was made. And we give the 3-vessel view, and of course our amazing staff, credit for picking this case up. So again, we start with the cardiac anatomy here, and the bedrock, as we say, is still the 4-chamber view. And on the left, we see the grayscale, and the 4-chamber view looks pretty normal overall. I think, especially in a busy unit with many cases coming through, I think that everybody would more or less like this view and feel like we're getting all the anatomy we want to see, the 4 chambers, the AV valves, as we discussed many a times. And if you're not sure, is this left ventricle fully forming? Is it normal? The color Doppler definitely helps you see that this is a pretty nice, well-formed ventricle. We talk about RV-LV discrepancy, but the RV is allowed to be slightly larger. And overall, I would say that this is a normal 4-chamber view. Now we go to the outflow tracts. So the outflow tracts, again, they're orthogonal to each other. They're right angles to each other. So you twist one way, then the other way. The left outflow looks normal here. It's continuous. The septum is nice and thick. They're continuous with the medial wall of the aorta. There's no defect there. The mitral valve's down here. On the right outflow tract, we see a little piece of the pulmonary valve over here, and the bifurcation with the ductus, as well as branch pulmonary artery, and a cross section of the aorta over here, all looking normal and unremarkable. Moving up in the mediastinum, though, and here's your 3-vessel view. And I wouldn't say this is the most overtly abnormal 3-vessel view, but let's talk it through. We have the ductal arch here and the pulmonary artery over here. The aorta may be similar in size, but maybe slightly smaller, nothing alarming, but then the SVC does seem large. In fact, in this view, where we see the branch pulmonary arteries coming off the pulmonary, and the pulmonary is bigger than the aorta, but the SVC is larger than the aorta. So I would say that from this view made us suspicious that something's going on because this SVC is too big. Now, my colleagues have shown a couple of cases of the SVC being a little bit off and showing how the azygous vein can attach to the SVC, representing increased flow from the lower half of the fetus. And when you see that again, it's important to look at the entire venous structures, looking at the IVC, looking at the ductus venosus if possible, looking at the pulmonary vein, just making sure that the venous return and the anatomy look okay. But here in this case, we're looking at the 3-vessel trachea view here, and we don't really see an azygous coming into that SVC. There's a trachea over here with no flow in it. You have the red SVC returning blood to the heart, but again, the SVC seems dilated. You can see it a little bit better here in the grayscale, but no obvious insertion into the SVC explaining why it's getting increased venous return. So let's look at the vena cave a little bit better as we're looking at the venous system. And this view helps us see that in this case, there's no interruption of the IVC as in the prior case that you've seen, but the SVC is significantly dilated compared to the IVC. So what this tells us is that it rules out interrupted IVC and it makes us say, we got to look elsewhere. So in summary, we basically just have a dilated SVC. There's no azygous. We had no cardiac anomalies. We had no venous anomalies seen in the pulmonary veins or in the IVC, and we have to start thinking, what does that mean? And the bottom line is understanding the connections as Christina went through, understanding what the vessels are supposed to do. We see that there is something going on with venous return. I see in the chat that somebody's guessing pulmonary venous, and I'll tell you that from looking at the 4-chamber views before that, we saw normal pulmonary veins. So what's going on in the upper abdomen? Now, the upper fetus. Now remember, like I said before, the venous structures can be altered in a lot of these malformations, and the return can come from the lower part of the belly of the abdomen and chest, and can insert with either bridging veins or anomalous pulmonary venous return or the azygous. But in this case, all that stuff seemed appropriate. So we have to look higher up, and so let's look into the brain to understand where this venous return is coming from. And we went back retroactively before we went into the room to do the diagnosis, to try to decipher what's going on. And these are the head views, and more or less seem appropriate. The anatomy looks fine. This is not a brain talk, but we have the CSP, and we have the lateral ventricle and the coral plexus. We have the posterior fossa, and nothing seemed off. Everything's midline and symmetric. We see the pericallosal artery and the corpus callosum here. But because we're looking for vascular structures, sure enough, we put on the power Doppler, and this is what we see. There were significant AVMs throughout the fetal brain, and unfortunately portending a very poor prognosis for this fetus. In general, we only picked this up because we saw a dilated SVC, because the grayscale images and even the pericallosal artery image on the anatomy did not necessarily identify or give us any clue that there was something going on. So again, it might be a little bit of a zebra, but the bottom line is it just shows that this 3-vessel view has diagnostic capabilities outside of the actual heart itself. And we hope that this talk has been able to help make that point and drive it home. So in summary, our final slide here, we want to look at the abnormal number of vessels for a 3-vessel view. And you can get a persistent LSVC, a truncus, or a transposition. It can have either, it can have look like only 2 vessels. The abnormal size we went through in terms of, is the pulmonary bigger, is the aorta bigger, is the aorta atretic, is the pulmonary atretic, abnormal orientation, right aortic arch and rings, and then abnormal Doppler looking for turbulence of flow as well as reversal of flow. That are the basic ways that you can go through this view and get a lot of information. So that's our final slide. Here are some of the references we used. I'm hoping that this approach to show that this is really a teamwork. I'm so proud of my team here, especially Christina and Matt, who have done such a wonderful job, not just for this talk, but overall in caring for our patients. And we're happy to take any questions.
Great. So thank you again to AIUM and Samsung and everyone attending for letting us go through this talk and prepare this webinar and presentation. It was certainly a lot of fun for us to collaborate on this as well. I think we have a few questions in the chat and everything as well. And so I think, one of the first questions that had come up was just about, if you're able to get a normal 3-vessel view, normal 3-vessel tracheal view, but you aren't quite able to get your outflow tracks at your 20-week screen, do you bring that patient back, in a few days or in a week or not, given that you've been reassured by the 3-vessel view? And so I'm not sure, Dr. Schwartz, do you want to take that question?
Sure. I think it's a very fair question. We're trying to make the argument here about the utility of the 3-vessel view, and we wouldn't want to be saying anything that is different from the guidelines. The outflow tracks still are super important, and your goal, whether you're learning your craft or whether you're trying to incorporate fetal imaging or fetal cardiac imaging into your tool set, I think the outflow tracks are still obviously very critical. But there are some situations where if we see a beautiful 3-vessel, and just because of positioning, we see the outflow tracks, they're just not perfect, I can see myself saying, you know what, instead of causing a lot of alarm to the patient and saying, I need you to come back next week or go get a fetal echo, I can see myself being confident enough to say, listen, you know what, you're coming back later in the 3rd trimester to check on a growth scan for whatever reason, we can just, get those images then. But it's a tough call, and I think there's a lot of art of medicine here. Are you counseling the patient? Is explaining it to them going to really increase their anxiety unnecessarily? And I think that a good 3-vessel view, 3-vessel trachea view, and 4-chamber is very, very powerful.
Great. And then there's one question in the chat here that says, what is the kind of the most problematic or common complication of transposition of the great arteries in children and the best treatment? And, and I'll start with that one. Thank you for the question. For transposition of the great vessels and everything, that is, commonly one of the cyanotic heart conditions in which there's parallel circulation and you don't get overlap, especially once the foraminal valley has closed after birth, that it's can become a ductal dependent lesion to get, cross flow between the oxygenated and the non-oxygenated blood. And so that really does require neonatology to be aware of that right around the time of delivery to see, does the, infant or neonate need prostaglandins to keep the ductus open, or do they need other surgical treatment? And certainly, I'm not by any means an expert in what that surgical treatment would be or how, when they, the specific criteria for it, but, it is, a very important diagnosis to make ahead of time so they can be sure to deliver at the appropriate center and have those treatments.
Yeah, I would second that. And I would say that of all the lesions, we talked about it earlier, that transposition and then probably tetralogy are some of the common lesions that can be missed on the 4-chamber. But of those 2 lesions, transposition is more likely to become a neonatal emergency after the first few days as the shunts and the ductus close. So of all the, like I said earlier, of all the anomalies in terms of actually improving outcomes, detecting these is really gonna have a significant impact in that child's life.
And then we have a question here that says, do you routinely take clips of all the heart views, or does a still image suffice? And I think this would be a great question for Christina as well.
Yeah, I can take this one. So our lab currently takes a 4-chamber cine clip as part of our anatomy scan imaging. I do think that a lot of our sonographers have found a 4-chamber to outflow tract clip where it's that 4-chamber up through the 3-vessel view and then the 3-vessel tracheal view, that clip to be very helpful. I think that we are taking those routinely on our anatomy scans, but it's not at this point a requirement from AIUM protocol. But I do think that we found that to be very helpful.
And then, Christina, there's a kind of a follow-up question here as well. Have you ever used the stick mode or or do you do the kind of acquisition manually through those sweeps?
Yeah, so if you're using stick, this is definitely something you can get. I do think that stick is one of those things where there's some limitations to it that there's not to doing this view on its own. So stick, a lot of times, if you're not able to get a good angle because of shadowing from the spine, that's really going to be on some of your stick imaging as you're kind of going back through that. At other times, this view itself, you don't quite have so many limitations when you're doing just the sweep through. So, I mean, I think there's value in doing those additional technologies like stick, but I also think that this view kind of stands on its own too.
Great. And then the last question that I see here is there a type of transposition of the great vessels where you can see 3 vessels in the 3-vessel view and 3-vessel tracheal view. And you know, I think that's opposed to what we presented was seeing 2 vessels, the superior vena cava, and then one of the arches, with the other being more inferior to it. You know, certainly in my you know, experience in reading, you know, typically those, you know, arches do tend to be, you know, superior and inferior to each other and not necessarily side by side. But I don't know, Dr. Schwartz, if you've had other experience or seen that.
Yeah, I think it's a very important question. You know, we're still, you know, and all the more reason why, you know, you shouldn't give up on the outflow tracts and just replace them with the 3-vessel view. There are indeed, you know, we are presenting a typical transposition of the great arteries, but there's often very more rare, but potential variants of that. And sometimes the aorta can be malpositioned enough where you can catch all 3 vessels in that 3-vessel view. So if it's not just a straight transposition, but there's other realignments or malpositioning of the aorta, you can, in some situation, get a 3-vessel view that looks okay. So another reason, like I said, to not, you know, discount the importance of the outflow tracts. But those are definitely less common and will often already have other things on the 4-chamber, like, you know, RV-LV discordance, or some other detection, some other clues on the 4-chamber view. So I wouldn't say this can't be a transposition in those situations, but the vast majority will have an abnormal appearing 3-vessel view, either the eye sign or malalignment of the 3 vessels.
Great. Okay, well, thank you all for all of the questions and everything as well, and again for the opportunity to present this.
Yes, and thank you again to AIUM and Samsung. Thank you to my partners here, and hope you guys enjoyed. And I'm sure we'll see you on the path with all the other AIUM educational experiences that are offered.
Thanks, everyone.
Great. Thank you so much, Dr. Schwartz, Dr. Jansen, and Christina for that amazing presentation. And again, AIUM would also like to thank Samsung for partnering with us to make this webinar possible. As a reminder, you will receive an email within 24 to 48 hours, the link to view the recording. We'll also go ahead and post that on the AIUM website. Lastly, when leaving today's webinar, you will be prompted to complete a brief survey. We would appreciate any feedback you could provide. We'll use that to help us plan our future educational offerings. So with that being said, we'll go ahead and close out this webinar. Thanks again for joining us and have a great rest of your day.